Welcome to the EAU podcasts.
Good morning, everyone. It's my pleasure to be at ASCO GU in San Francisco this year. Today, we have the honor to be with Professor Galsky from Mount Sinai, New York. And Professor Galsky just have presented a very, very awaited study, the EV-B15, talking about EV pembro in the peri-operative settings in patients that are cis-eligible. Matthew, thank you very much for your time.
Thank you. Thanks for having me.
We are very happy to have you. Can you tell us a bit, before we go through the design and the results of the trial, can you tell us what is the rationale behind this trial?
So enfortumab vedotin plus pembrolizumab is now standard treatment for patients with metastatic urothelial cancer since the EV-302 study. And because of the activity and safety in patients with metastatic disease, it was quite logical to move that to the peri-operative setting, where frankly, we've had no major improvements in treatment since cisplatin-based chemotherapy was shown to be beneficial almost 25 years ago. And so B15 was designed, KEYNOTE-B15, which was the study that I presented, and then a sister study, KEYNOTE-905. Mm-hmm. These were asking complementary questions. B15 is this regimen of clinical utility in patients who are cisplatin-eligible versus cisplatin-based neoadjuvant chemotherapy. And KEYNOTE-905 is this regimen of clinical utility in patients with muscle-invasive bladder cancer who are cisplatin-ineligible, where cystectomy alone would be standard of care.
Mm-hmm. And so we have already the data from ESMO 2025 showing a huge benefit of EVP in this setting of cis-ineligible patients with a complete response over 57%, and primary and secondary endpoints, PFS and OS, were positive for this arm. What is the administration that you given to this patient in BV15?
So in B15, it was almost identical with one nuance. In the experimental arm, the EV pembro arm, instead of 3 cycles of neoadjuvant therapy prior to cystectomy, here it was 4 cycles of neoadjuvant therapy prior to cystectomy. And then in the adjuvant setting, 13 cycles of adjuvant pembro, the first 5 of which were administered with EV.
And the comparator arm?
Was GemCis, 4 cycles, followed by cystectomy, followed by observation. Adjuvant nivolumab could be administered where clinically indicated and regionally available. Okay. And of course, that was different depending on region.
And why did you choose to get 4 cycles of EVP? Because patients are cis-fit, so better toleration?
That plus it aligned better with the duration of standard neoadjuvant therapy. So in the absence of a comparator or systemic therapy in KEYNOTE-905, there was the ability, and because those patients are perhaps a little bit more frail, there was an interest in more limited treatment before we get patients to definitive surgery. Here, you wanted to make sure that the regimens were of equal duration.
Great. And so let's go to the most important part about the results. Can you tell us what are the main results of the trial?
So event-free survival was the primary endpoint. The main secondary endpoints or key secondary endpoints were pathological complete response rate and overall survival. The study was powered to assess those with recycling of alpha if necessary. And so what I presented was interim analysis 1, and at interim analysis 1, all 3 of those endpoints met. The primary endpoint of EFS, and then OS and path CR rate as key secondary endpoints. In terms of the EFS endpoint, the hazard ratio in favor of EV pembro versus GemCis was 0.53. In terms of OS, the hazard ratio in favor of EV pembro versus GemCis was 0.65. And in terms of the path CR rate was 32.5% on the GemCis arm and 55.8% on the EV pembro arm. The EV pembro path CR rate almost completely aligns with KEYNOTE-905.
Yeah, that's what I want to say. Yeah. So the results were mostly similar for PCR, right, at least. So these results are tremendous for our patients. We see that we have raised and get over the famous 50% PCR, for example, for the patient. And of course, it has an impact on EFS and OS, and we see it today. How do you see, first of all, do you think that this is a new standard of care from tomorrow on?
I do think it is.
And for every patient, from cisplatin-ineligible and cisplatin-eligible.
That's correct.
Okay. Do you have, so maybe now we need to discuss, because it's going to change completely the way we're going to treat our patient in the next coming months. How do you approach, you are the first author of this famous paper published in Nature with Nivo Gemsis on complete response and the advantage of clinical complete response. We will see a lot of patients coming to our office after EVP and asking for not going through cystectomy anymore. How do you approach this new data with such a high PCR? And how do you think, should we completely stop to do cystectomy for these patients?
So the PAT-CR rate is obviously quite high, such that patients are going to be asking this question. Of course, want to respect patients' desires to keep their bladders intact. At the same time, not proceeding with cystectomy is still a departure for standard of care, and we need to develop this evidence base very carefully and thoughtfully and ultimately do comparative studies if those studies are indeed feasible before this becomes a widespread approach. My concern about doing this too soon is that we've tried to do this in a very stepwise manner to minimize the risks as best as possible because the stakes are quite high. 5 to 10 years ago, we weren't thinking quite as much about how we de-escalate treatment. We were thinking about how we cure more patients with muscle-invasive bladder cancer. And I think now we're starting to think about how we can back off, but we need to back off quite carefully.
Yeah. Do you think that have you been able to look into the trial about ctDNA and the profile of this patient with negative ctDNA after EVP first treatment?
No ctDNA data yet, but that's planned.
Okay. And you think that it's going to drive, as we had with atezolizumab, for example, the way we're going to discuss with the patient bladder sparing strategies?
I think ctDNA in this context is going to be a little bit of a challenge from a bladder sparing standpoint. And my reason for saying that is that we just published data from HCRN GU16257, the Gemsis Nivo bladder sparing study in PNAS, where we looked at an ultrasensitive ctDNA assay and urine tumor DNA assay. And we actually have data at ASCO using with version 2 of our bladder sparing approach, which was single agent pembro. And in both of those studies, using different ctDNA assays, both ultrasensitive but different assays, we see that 100% of patients with a clinical CR have undetectable ctDNA. So ctDNA doesn't necessarily add to clinical CR in that context because everyone has undetectable ctDNA. What's pretty interesting is in patients who don't have a clinical CR, ctDNA seems to be incredibly helpful in identifying patients who then have a high likelihood of being cured proceeding with cystectomy versus those who don't. So there's a lot to talk about using ctDNA to define who doesn't need to have their bladder removed. I think it's actually a little bit of a flip of the question. I think ctDNA is going to be useful in that context to determine in patients who have pathological evidence of residual disease on clinical restaging, who should have their bladder removed versus not. Urine tumor DNA, I think, is a different story, and I think that's going to be quite helpful.
Sure. Very interesting discussion. I have some question regarding the EFS. It was the primary endpoint. What was the EFS at 12 months? Do you have some data on 12? Or?
Yes. Yes, I do. The EFS at 12 months was actually among the highest reported in this patient population in a clinical trial to date. And it was 24-month EFS was 80%.
Wow. So it's really like we are going to cure or hopefully cure this patient more and more. As you said before, we wanted to just preserve them and treat the MIBC, but now we are going to cure 80% of the patient without any events at 2 years. That's completely dramatically changing the way we're going to approach MIBC, I think, in the next coming years. But what about this patient that's going to recur and have progression? We had EVP as first line treatment for metastatic. How do you see? Do you think that we can re-challenge these patients? Time from the last doses to progression? How do you believes that we need to have the approach for the next step in first-line treatment?
So I do think that probably matters. I think time since last treatment probably matters in terms of rechallenge versus not. I have no data to back that up. It's arbitrary. It's sort of a line in the sand. But I think traditionally, at least I've thought of peri-operative treatment as either curing cancer or not. But I think with ctDNA, my thinking is a little bit different in that we certainly have patients who are getting adjuvant treatment, for instance, with ctDNA testing serially, who have a decline in their ctDNA and oftentimes clearance, and then it starts to rise again. And that tells me that which should have been obvious from the metastatic setting, there's probably more of a spectrum. Perioperative treatment probably cures some micrometastatic disease. In other patients, it probably decreases the burden substantially, but doesn't completely get rid of it, such that off treatment, it starts to grow again. And just like a patient in the metastatic setting who has regression on a systemic therapy regimen, and maybe you stop it because they want a treatment holiday and then you start it again later, I think it's quite analogous to this.
Yeah, totally agree. Maybe last question, because you were raising all these points. You said that there are 13 cycles of adjuvant therapy with pembro after surgery. Do you see that some patients, especially maybe with ctDNA, will require a longer treatment, or even though in the way around de-escalation with less treatment if you have PT0, ctDNA negative after surgery? How do you think that there will be like a room for improvement for these patients?
Yeah, I think that's, of course, the $1 million question. The Niagara data is the best data that we have to try and address that. And of course, as you know, in patients who had a path-CR who are ctDNA negative, there still seemed to be a benefit on the durvalumab containing arm. Now, the challenge with interpretation of that data, which is the same as data that might come out with B15 with ctDNA, is that you still don't know that that benefit wasn't driven all by the neoadjuvant phase of treatment. So it doesn't totally tell us that you need the adjuvant portion or not, but it does make one want to continue the treatment as prescribed until we have evidence stating otherwise.
Okay. Thank you very much, Matt, for your time. Congratulations for this amazing study that you have presented today at ASCO GU. It was a pleasure to have you here. I wish you all the best for the next coming months, because I think you're going to be very busy with all this new data.
Thank you.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform, UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.